Hey everybody, welcome to today's video. It's that time again. It is May 1st and you know what that means. Sacramento County is rolling out a set of new policies and this is your video. All right, but this one's a little bit different. I'm bringing in three friends who are gonna help me shoot this video. We're gonna go around the room and introduce everybody. Shooting on location today at different spots. So Dr. Alex Schmalz with the Sacramento Metropolitan Fire District. We've got Dr. Brian Sloan with Folsom Fire Department, and we have Dr. Tressa Nike. She's the medical director of both the dispatch center and also for Cosumnes Fire District. So, welcome. We hope that you enjoy this video and we hope it brings you some information that you didn't know before you came in. I'm going to give you a little bit of a hint. There are 9 policies that have major changes in them. So the rest of them are fairly minor changes or no changes. And in addition to that, in this video, I wanted to bring you guys some pro tips. What do I mean by that? Like pro tips, like when I look at a policy, what am I thinking about? And hopefully giving you guys just a little bit of extra edge in that policy, and most importantly in the patient treatment. And so each of these experts is gonna bring to you guys some pro tips. All right, so let's take it away. We're gonna go around the room and introduce ourselves right now. Alex, why don't you take it away?
Hi, I'm Alex Schmalz. I'm the medical director of Metro Fire. I'm at Station 109 here, home of the Mobile Integrated Health Unit, and I'm happy to talk with you guys today.
All right, let's head on up to Folsom. Let's introduce you to Dr. Brian Sloan. Brian, say hi to everybody.
Hey Kevin, we're here at Fire Station 38 in Folsom, California, home to Engine 38 and a spectacular crew of firefighter paramedics who have welcomed us into their home, and we're gonna have some coffee and talk about policy.
All right, that's great. All right, let's take you on down south to Cosumnes Fire Department and introduce you to Dr. Tressa Nike. Tressa, say hi to everybody.
Hi, my name is Dr. Tressa Nike. I'm currently the medical director for Cosumnes Fire Department, and I'm also the medical director for Sacramento Regional Fire and EMS Communication Center. And currently we are at the new Fire Station 77 at Cosumnes Fire Department.
Fantastic. All right, so this is my band of brothers and sisters, and we're gonna go through these policies now one by one. All right, so let's kick this party off. I'm gonna send it on over to Station 109. Dr. Schmalz, what do you got for us for our first policy?
All right, so policy 2033 doesn't have any huge changes. The big thing is that it has an emphasis on determining death within the first 30 seconds of arrival. So you can start CPR, you can start basic treatment, and you can do all those things while you're assessing for death. So I kind of consider that like your train's picking up speed, but it hasn't really left the station. After about 30 seconds, a minute, it's probably left the station. You should probably continue treatment, but you really have that time, that first initial 30 seconds to really figure out whether or not you're going to be doing treatments, whether or not you think the patient's already dead. And then the other two kind of big things to emphasize on this one are for traumatic arrest. The things to look for are the absence of pulses, or whether or not there's asystole in 2 leads or wide complex tachycardia that's slower than 40 beats per minute. So those are kind of the big things to look out for on this one.
All right, beautiful. Thank you so much. Dr. Nike, what do you got for our next policy?
All right, so 8001, as we said, allergic reaction to anaphylaxis. Remember, when you're evaluating any kind of patient with possible allergic reaction to anaphylaxis, wheezing is paramount. If the patient has any wheezing involvement, this is anaphylaxis. You want to make sure you maintain this oxygen saturation is greater than 94%. Give epinephrine 0.3 milligrams IM up to 3 doses maximum, and albuterol for wheezing in large doses, 5 milligrams. With regards to push dose pressors, for example, like if the patient has stridor or they have hypotension, be quick about your decision, but administer it, get it started so the patient can be treated correctly.
Awesome job, all right. Dr. Sloan, what's up next? Take us to our next policy.
So Kevin, this one actually has some big changes that I think are really important to talk about. So as I'm sure you know, and I'm sure everyone's seen, our opiate overdose patients nowadays are not just overdosing on opiates the way that we knew them 5 or 10 years ago. There's a lot more synthetic opiates out there that are way more potent and can last a lot longer than the heroin and fentanyl that we're used to. And because of that, we've seen patients require massive doses of Narcan to get them reversed. And so this policy was changed to remove a cap on the amount of Narcan that you can administer. So if you've got a patient that requires 10, 15, 20 milligrams of Narcan to get them breathing again, we can do that because that is what we're seeing. Now, obviously, if there's something else going on, the Narcan's not going to work. So don't put all of your eggs in one basket with Narcan, but know that these patients are requiring much heftier doses to get them to respond. So as a reminder, if you're BLS, you can do 2 milligram or 4 milligram preloads, and you can continue to repeat them every 5 minutes until you get the desired effect. And don't forget to check a blood sugar because that is frequently a cause of somebody not being responsive. For paramedics, it's 1 milligram IV or 2 milligrams IN repeated every 5 minutes until you get effect. And what's the effect we're looking for? We don't want them awake. We don't necessarily want them talking to us. We just want them breathing. That's the goal. We're hitting that level where we want them awake enough to support their own respiratory drive, but not awake enough that they're getting pissed off and trying to fight you or trying to AMA where they're going to have a repeat episode after the Narcan wears off.
Okay. One other big thing about this policy is it now includes leave behind Narcan kits or leave behind naloxone kits. These are really important because if you consider that you're giving somebody Narcan in the fields, there's a really high chance that they'll need Narcan again in their life. 10% of the people who we give Narcan to in the fields die within the next year. That's a really important statistic. That you compare that to a STEMI and the way we treat a STEMI. 11.5% of the people who have a STEMI die within next year. So this is a really, really high risk population. And we're now factoring into this protocol the ability to give people and their families and their loved ones leave behind Narcan. So essentially that you can give them the medicine that they need to reverse an overdose if they have it in the future. So hopefully in the future we'll be responding to an overdose of somebody who's alive rather than a CPR of somebody who's dead.
Fantastic. All right. Hey, thanks so much for that. You guys got some good tips, little nuggets in there. Let's head on over to Dr. Nike for the next policy.
Policy 8020, Respiratory Distress and Airway Management. It is the same policy, but a little exception here, in that when we have inadequate oxygenation and ventilation with the 4th attempt with an eye gel, we need to divert to the closest ED with a failed airway pre-alert. Some of the pro tips with regards to respiratory distress and airway management we should take into consideration. Don't forget to have backup bougie, have it ready at the patient's bedside or at least within reach. Use end-tidal CO2 if available on all patients without fail. Be sure to let it zero before using it.
Fantastic. Awesome. All right, Dr. Smalls, what's next for us?
All right, so this is a big rewrite, and there's a lot of big changes on here, so we'll take a second to kind of discuss them all. One of the big things is that how we measure the burns is changing. So we're using the HandTevi app. That's one of the big things. It has a guide for estimating the burn size under additional resources as part of the app. Another thing is that we want to do 20 minutes of cool running water. That's really important. Doing this in the field as soon as possible will actually make a big difference in terms of outcomes. And we do that for patients with less than 30% total body surface area burns and patients with no airway involvement. That's really key. If they have airway involvement, get them to the place they need to go, get them to the ER. But if they have less than 30% and no airway involvement, cool the burn, but warm the patient. So cool the burn with cool running water, and then warm the patient up. Make sure that they stay nice and warm and insulated. Another thing that's up to date with this is that we've added on no adhesive dressings, and you can use plastic wrap. So if you work in a department that stocks the plastic wrap, you can put the plastic wrap up the arm and down the arm, and that actually keeps the pain down on the patients because it prevents the air from accessing the skin and causing that like kind of severe burning pain that the patient's going to have. So it'll actually make the patient feel a lot better. Another couple of pro tips on this one. So if you're intubating, if you need to intubate, use an size 8 ET tube, at least, because that allows for the bronchoscope to go through. Another thing is that ketamine is an excellent pain medication for these patients. That's ALS only, so keep that in mind. And then remember the criteria to take the patient to UC Davis. This is the big burn center in the county. We need to know this criteria. So it's if you have greater than 9% total body surface area, if you have electrical or chemical burns, if you have any inhalation injury, all reasons to go to UC Davis, and then if the burn involves the face, hands, feet, groin, or major joints such as the elbows or the knees, go to UC Davis. Those are all really important things, and they need to get the definitive care there rather than going somewhere else and then getting transferred and just causing unnecessary delays and pain for the patient.
All right, beautiful. Thank you so much. Dr. Naik, what do you got for our next policy?
Policy 8026, respiratory distress. This is basically algorithm-based. There's not really major changes. Remember, when you're looking at this algorithm, albuterol is always the first step. Nitroglycerin and this is for mild to severe asthma or even in CHF. Nitroglycerin will be the second step in those with CHF. Epi follows albuterol in severe asthma, 0.3 milligrams IM. Non-invasive ventilation is both severe distresses, that means CHF and with asthma and COPD to be utilized. Push dose pressors is allowed in both for hypotension, but if you're having an asthmatic with severe hypotension, you need to think about possible anaphylaxis, not asthma as the cause.
All right, Dr. Sloan, what's up next? What do you got for us?
So this policy does have a couple changes, Kevin, and I think they're good changes. So really importantly with traumatic cardiac arrest, this is very different than medical cardiac arrest. I just told you that for medical cardiac arrest, you should stay in play for a little while and stabilize your patient after you get ROSC, and definitely not transport a patient who's getting CPR if it's a medical cardiac arrest. For trauma, completely opposite. If you've got a trauma who's in cardiac arrest and you're going to work it and transport it, go and go now. The patient needs a surgeon, they need an operating room, they need blood, they need all the stuff that we can't do for them in the field. So the most important thing for traumatic cardiac arrest is early and aggressive transport. Now, if they have a wide complex PEA or in asystole and they're in a rate less than 40, if they're in that wide complex PEA, they meet determination of death, okay? For everybody else, start CPR and get moving. An important thing also is that they need volume. So use a pressure bag to get some fluids in during transport to try to pump up their volume a little bit. With that, you honestly want to make sure that you're not giving too much, right? We don't want them to have 2 liters in 15 minutes and blow out all their clotting factors, but the amount of fluids that we're going to give them, we want in fast. Try to buy them a little bit of time, just with caution to not give too much. On top of that, no epinephrine. Epinephrine in traumatic cardiac arrest is not helping anybody, so don't do it. With that, think about a bilateral needle thoracostomy. And in fact, I would say on every traumatic cardiac arrest, unless it's very clear to be isolated head trauma or isolated something else, do a bilateral needle thoracostomy. There may be a tension pneumo that's hiding that you can relieve and get the patient moving in the right direction.
Okay, thanks so much, Dr. Sloan. Let's head south. Let's let Dr. Naik take the next policy. Dr. Naik, what do you got for us?
Policy 8063, nausea and vomiting. There have been no significant changes. If you do carry Zofran ODT and you think the patient is waiting room appropriate, this is a great medication to give them versus starting an IV and giving IV Zofran.
Awesome, loving it, loving it. I hope you guys are getting a lot out of this. Got some good nuggets in here. All right, Dr. Sloan, what do you got for our next policy?
Thanks, Kevin. So the changes here are really more about the criteria at which you're going to start treatment and do a sepsis pre-alert to the hospital. So if you've got a patient who is got a suspected source of infection and is meeting the SIRS criteria, you definitely want to think about sepsis. Sepsis is still a major killer of people both inside and outside of the hospital, so we want to treat it aggressively. We've noticed that patients who are meeting this criteria are really not getting fluids at the rate and amount that we want. So one of the big recommendations we're making here is to use a pressure bag to get these fluids in quickly, but also make sure that you're identifying the right patients and doing your frequent reassessments as well. So with these patients, the criteria that we're looking for are our standard SIRS criteria. But to make that pre-arrival criteria and to start treatment, we've also added hypotension or a low end-tidal CO2 as criteria. So if you have a patient who's got a suspected source of infection and is meeting SIRS criteria and or has hypotension or low end-tidal, you would start the fluids with a pressure bag and give the hospital a pre-alert.
All right, Dr. Sloan, that was great. Thanks so much. Hey, we're going to head on over to Dr. Smalls next for our next policy. Take it away, Alex.
The MIH is about to go on a call, so hopefully they see something good and or help prevent somebody from having to go into the ER. All right, so the pediatric airway management has another big change that's really similar to the adult change, and it's along the lines of if you have 4 attempts with an I-gel and you can't ventilate and you can't oxygenate, so again, can't get good end-tidal CO2 for ventilation, and you can't get good oxygen saturation or SpO2, you take those patients directly to the closest ER as soon as possible, and you call a failed airway alert. This is so that they can get all of their resources necessary, because if you couldn't do it, they're probably gonna have an awful lot of trouble doing it unless they get all of the resources they have in the ER. So when you call that failed airway alert, you're calling in backup and backup and backup, and you're getting everybody ready to take care of that patient.
Let's head on over to Dr. Nike for the next policy.
Policy 9007, Pediatric Diabetic Emergencies. Just remember, dextrose doses are all now listed in milliliters, and that's because that's what's found on the HandTevi app. So what did they remove? They removed dextrose 0.5 grams per kilogram up to 12.5 grams. Also in children 14 plus years old, D50, 50 milliliters preload, which was the full dose, they've removed that. Drinking of the D50W like kamikazes, no longer as an option, sorry. So what did they add? Under 2 years old, you give D10, 5 milliliters per kilogram. For children 2 to 14 years of age, D25, 2 milliliters per kilogram, or if you have D50, 1 milliliter per kilogram. Don't forget, bolus normal saline in hyperglycemic patients, defined as blood glucose greater than or equal to 350 milligrams per deciliter.
Heading back up north to Metro for our next policy, Dr. Smalls, what do you got for us?
So pediatric seizures, a couple of pro tips, no big changes. So as far as the pro tips, for the IV and IM doses, the max dose is 4 milligrams. For the intranasal dose, the max dose is 6 milligrams. So just really important to memorize those two things. 4 milligrams for IV and IM, 6 milligrams for intranasal.
Awesome, loving it, loving it. I hope you guys are getting a lot out of this. Got some good nuggets in here. All right, Dr. Sloan, what do you got for our next policy?
Thanks, Kevin. I think this is another protocol that's really important to talk about because this is another one that really makes people uncomfortable. So there's no major changes to this protocol, but it's really important that we hit on a few really important points. And that is, kids in cardiac arrest are a little bit different than adults, but our core premise is still the same. Good CPR is critical. If we're not doing good CPR for these kids, they are not going to survive. And so a lot of people are really uncomfortable with peds cardiac arrest, but the big thing to remember is compressions. Now it differs a little bit from adults in that kids who are in cardiac arrest are usually in cardiac arrest because of some type of respiratory problem, some type of hypoxemia, drowning, something that happened. So definitely work on your airway maneuvers and work on securing an airway and get them good ventilation, but don't stop CPR to do so. Now, when you're starting to deal with your ventilation, the biggest marker that you're going to have to see if you're adequately ventilating that kid is chest rise and fall. So make sure you're targeting to that, to see that chest rise and fall, to make sure that you're getting adequate ventilation. Now, another really important point that makes a lot of people uncomfortable is that scooping and running kids in cardiac arrest is not the right thing for them. We can't do good CPR in the back of an ambulance no matter how good it is, especially on a kid. We can't do good CPR if we're grabbing the kid and holding them and running and trying to do compressions. All of that time that we're scooping and running is essentially time without CPR. We're just prolonging their downtime. And it's really, really, really hard to be in that family's house and to see those parents and to not move, because every fiber of your being is saying, go, 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 go. I get it. But if we want the best outcomes for these kids, staying and doing CPR is the right thing for them. Now, I'm not going to sit here and tell you to spend 20 minutes on scene and to not transport them. I think it's totally reasonable to, at a certain point, go. That's fine. But definitely spend at least a few rounds of CPR trying to get ROSC, because the kids really, really, really need that good CPR up front. And it goes against every fiber of your being, but know that you're doing the right thing by not just scooping and running.
Fantastic pearls of wisdom. Thank you so much. Dr. Naik, what do you got for us?
Policy 9009, neonatal resuscitation. Essentially, there are no changes. But here's some pro tips. APGARs, that when you actually determine them, do not occur at birth. Wait 1 minute and then repeat them at 5 minutes. It is algorithm driven. So the first thing you want to do is stimulate the patient. No response, then you're going to do positive pressure ventilation, followed by compressions if needed. Compressions are started for a heart rate of less than 60.
Perfect. A lot of really good tips there. Thanks so much. Why don't we send it on over to Dr. Schmalz for our next policy.
So pediatric overdoses, this covers all the big overdoses. So beta blockers, opiates, calcium channel blockers, tricyclic antidepressants, so TCAs. There's no big changes to the protocol. Some of the big pro tips are with the ones that are vasoactive, so beta blockers, calcium channel blockers. Just be ready with those push dose pressors, because those patients can get hypotensive really quick, they can get bradycardic really quick, and having that push dose epi around is really going to help bring up the heart rate, bring up the blood pressure, and help the patient stay stable en route. Also remember that you can use the Hand-Tevi Vitals tab, and this gives you the normal ranges for the systolic blood pressures, for the heart rates, for the pediatrics by age. For tricyclic antidepressants, recall that bicarb is the treatment of choice, and the first sign of overdose with those is tachycardia. So don't wait for the wide complex, don't wait for the arrhythmias. If you see the kind of significant tachycardia, just go ahead and give the bicarb. And the dose for bicarb is 1 milliequivalent per kilogram. And so you can use the Hand-Tevi app and just use the Hand-Tevi app. It is a great resource.
All right, Dr. Sloan, what's up next? What do you got for us?
So no major changes to this policy, but definitely some things worth thinking about and talking about. Kids can get really sick from shock, and it often can be masked. Kids compensate very well, so a kid who's in septic shock might not look like they're in septic shock right away. So you really have to use your good detective hat when you're assessing these kids and look at their mental status, their skin perfusion, their overall circulatory state to catch them early before they devolve into decompensated shock, because that cliff comes pretty quickly and these kids look stable, 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 fall off the cliff. So there's no major changes to this policy, but definitely, early intervention, early treatment, and early recognition is important. And with pediatric shock, the most common thing that you're going to see it from is septic shock. And I think this is particularly paramount in kids that have, chronic medical problems, complex health, indwelling tubes and lines. The more complicated kids are a lot more at risk. Not saying your normal kids aren't, but if the kid is more complicated, definitely have your sepsis detective hat on and really think about it early.
All right, beautiful. Thank you so much. Dr. Naik, what do you got for our next policy?
Policy 9014, pediatric cardiac dysrhythmias. No major changes to this policy. Here are some pro tips. Bradycardia is exceedingly rare. Most likely it is a primarily respiratory cause, which is related to hypoxia, congenital causes in which the patient was born that way, or an overdose. They got into grandma's medication or their mom's medication, and this is the result. Tachycardia is, by the way, far more common. Consider sinus tachycardia with fast, narrow, regular rhythm, and SVT, which is fast, narrow, regular rhythm also. Pause and consider most likely the cause. If SVT, think vagal maneuvers and adenosine. And kind of those vagal maneuvers can be carotid massage or blowing into a syringe. You have many options.
So pediatric trauma. Remember the big things on this. Keep the patient warm. So if you let the patient get cold, that'll exacerbate all the traumatic pathology, it'll exacerbate the coagulability, it'll make things worse. So keep the patient warm, and then if the patient meets trauma criteria, critical trauma criteria, and they're less than 14, those patients all go to UC Davis. So just remember the destination and keep the patient warm.
Policy 9021, pediatric behavioral crisis, no major changes. Pro tips, perform a detailed assessment including vital signs. If any medications have been given, please document those. Utilize the cardiac monitor, your SpO2, and highly advisable to add end-tidal CO2 in your monitoring of this patient.
All right, so we went through a lot of material. I want to thank my guest stars again, Dr. Smalls, Dr. Sloan, and Dr. Nike. Thank you for joining me. Thank you for being my partners in crime. I think with the four of us working together with our EMS divisions, I think we've done some amazing things and the future's bright. So I hope that you enjoyed today's video, that you got something out of it. Of course, please go ahead and send us questions. If you have any questions about it, run them through EMS division. We want to thank Dr. Can and the Sacramento County EMS Agency for their support, and we'll see you on the next EMS update.
It's a goat. You, okay.
With a diaper on.
Can I just say, you sons of bees, while I'm trying to be serious, bring a goat in. God damn it.
Hey everybody, welcome to today's video. We have some special treats for you today. I have 3 friends with me, but first, let me introduce you to where we're at. So I'm at the Sacramento, I'm gonna beat the holy hell out of that train. My gosh, no one needs to honk a horn that much. Man, this is frustrating. All right. Three,